Our next speaker is Dr. Heather Schickendanz, who I'm honored to call a colleague and a collaborator and a conspirator in the LA County Department of Health. Dr. Schickendanz is a fellowship-trained geriatrician, currently chair of the Harbor UCLA Department of Family Medicine, and prior to that position was director of primary care at our sister hospital, Olive View Medical Center. She holds faculty appointments at the UCLA Geffen School of Medicine and is co-PI with myself on the LA County Department of Health site for Dementia Careware, of which there is a table in the back on the far end from UCI, another one of our partners, if you're interested in learning more about Dementia Careware after she tells you what we've been doing. Her talk this morning will focus on improving early detection in underserved communities, results of Dementia Careware. Please welcome Dr. Schickendanz.
So we just got back from the Dementia Careware Summit this week, which was really fun over in Newport Beach. And part of what makes it really fun is that we always have a lot of jokes that are told. So there's one that's very near and dear to my heart that I love that was told, and it's, how do you know when a joke is a dad joke? Well, when it becomes apparent. Nailed it. Okay. So I am really delighted to speak with you all today about something that you've been hearing about, hopefully, from Freddie and others, that's called Dementia Careware, and specifically about dementia screening in primary care. So let's see if this works. So I have no relevant commercial disclosures, financial disclosures, but I do have an important personal disclosure, which is that first and foremost, I'm a primary care physician, I am a daughter, and I'm a mother. And as a caregiver for both the young and the aging, some of whom have cognitive impairment, some of whom have cognitive development, and also trying to weave in cognitive screening in primary care, this is a really important disclosure that I am extremely passionate about this, and my goal is to convert all of you to become extremely passionate about it too. One of the things that happened in our Dementia Care Aware Summit this week is that a very provocative question was asked, so I'm going to ask you guys too. And I'd like to see with a show of hands, how many of you are likely to die someday? Oh, okay, almost everybody. I'll talk to those of you who didn't raise your hand. Go ahead and raise your hands again if you're likely to die someday. And then keep your hand up if you think you're also likely to die with dementia. Okay? How about raise your hand back up or keep it up if you're likely to care for somebody who is living or will die from dementia? Okay. All right, well, if you look around the room, everybody's hand should have been up. As we heard, this is a very growing concern across our state, in particular for populations who are more vulnerable, but really for all of us. This is affecting all of us. So my goals here are to talk about Dementia Careware and really to make it relevant for each of us, each of you and me, okay? So the first thing that I wanted to say is that our goals for the program are to provide higher quality of care for aging patients in the Department of Health Services through implementation of annual screening using a cognitive health assessment, a screening tool that can be done in primary care, okay? That's upstream from, we already have end effects or late stage dementia, we're already facing institutionalization, this is very early upstream. Secondly, to integrate team-based screening. So team-based meaning it is not just the primary care provider, the physician or clinician that is embedded in sort of the hamster wheel 20-minute visits, but really team-based. So really working with our nursing and social work colleagues, as well as each of us as caregivers and or patients. And then finally, to document screening in our EHR for care coordination and regulatory compliance. And I would say for just broader awareness and public health efforts, we need more funding and research, and if we don't document what we're doing, guess what? Nobody knows we're doing it. So these are some of our goals. I don't really need to go over this slide because I'm pretty sure you've heard it, and I'm not going to do it justice after what you've heard from other speakers this morning, but we know that many of us will develop Alzheimer's or some form of dementia. We know that the number of Californians who are 65 and older who are living with Alzheimer's is projected to more than double to 1.5 million by the year 2040. So as a family physician who trains family docs, I tell them, unless you're going to go into pediatrics, you are going to be helping people, supporting people, diagnosing people, caring for people with dementia. And then we've seen that this is now the second leading cause of death. And it's also, I would say, probably right up there in the top cause of death, because we know that many of the same risk factors that apply to heart disease are those that apply to dementia. And many people will die with dementia, not of dementia, right? Also, we're not doing a great job diagnosing. So once we improve diagnosis, I think those numbers will increase. And that's not something I'm necessarily looking forward to, but I am thinking that it is something we have a responsibility and accountability to do. Okay, so let's talk about LA County Department of Health Services, where I'm very proud to work. It is a very large public health system. As you may be aware, it's probably the second largest public health system in the country. And in that health system, where we care for over 50,000 unique patients who are 65 and older, we ran a small, stats and found that we only had about 1,600 with a diagnosis of dementia. Or who were on a medication for dementia. So we knew that there was a big gap in our screening and diagnosis of this condition if we compared to across the national averages. So this was a good starting place for our dementia Careware journey. We have been working on this in primarily 4 different pilot clinics, and many of the people who are working on this are here in the audience or on virtually, but I'll just point out the 4 pilot clinics where we've been doing this for about a year are Rancho Los Amigos, right here, as well as Harbor UCLA Internal Medicine and Geriatrics Clinic, Martin Luther King, as well as Lomita Family Health Center. So you can see here our launch dates for when we began our pilot, which I'm going to be telling you about. So Harbor UCLA started December 2022, Lomita in March 2023, MLK April 2023, and Rancho Los Amigos in July. So we've been doing this for a little over a year. We've started with an emphasis on training and workforce awareness. There are many wonderful resources out there for training, many of which can be accessed for free online, very high quality. Alzheimer's Association, big shout out. They've been doing this awareness and education for patients and caregivers, for the public for a very long time, as well as our colleagues in the Dementia Careware at UCI, who have been producing really relevant, for clinicians at least I can speak for, really relevant library of resources around cognitive health screening as well as next steps. What we've been doing is actually a more local hands-on approach where we've been training in person 234 of our providers, and that has been really important because they can actually engage in a dialogue and speak to how it's implemented in our health system, dementia screening in our health system. We've had 12 in-person trainings. Here you can see Freddie doing a training right here. And we're really focusing on, again, team-based awareness and training. Phase 1, implementation of the cognitive health screen in primary care. So this is Sayaka Tokumitsu. She's our lead at MLK, and she's showcasing a really bling sort of, flashing lights display of our paper-based screening tool. So at this point, what we're doing, and this is changing soon, I'm happy to share, is that we have a pretty labor-intensive process for sort of reminding and then supporting primary care clinics to do this screening in our pilot sites. We have a coordinator who puts a sticky note. It's an electronic sticky note, so we're being nice to Mother Earth. No real paper sticky notes flying around. We have an electronic sticky note that we place in the chart for all of the patients 65 and older who are seen in primary care in these clinics who do not already have a diagnosis of dementia, to alert the care team, the provider, that this is something that they should do. The primary care provider does a 2-sided front and back CHA, cognitive health assessment, which is available in English and Spanish and has gone through many, many iterations to get it right, because we're really trying to be sensitive to the cultural and language needs of our patients. So we've been doing a lot of iterations of our paper-based form. So right now it's being done by the primary care provider, so hold that thought. Nursing adds patient's MRN barcode sticker to the completed CHA form, and then that actually gets scanned, that gets submitted to our coordinator, who then enters the data, and then we're actually scanning it into the health record. So very labor intensive. Here is our team-based workflow. It's really small. You don't have to read it. I basically just set it. And then here's where we're at. So I think it's really remarkable that in a year in very busy primary care clinics where we have staffing shortages and juggling many priorities in terms of screening, chronic care, and acute needs, we have done over 800 screens. So at Rancho Los Amigos, we have 15 screens and counting, 9 positive. At Lomita, 84 screens and 15 positive. At Harbor UCLA, in the other clinics, we have 582 screens with 196 positive, and at MLK, we have 136 with 40 positive. So overall, we have over 30% positive screens. That doesn't mean that everybody who's being screened for has dementia, but it means that there's more work that needs to be done, right? Now we've raised awareness, we've identified people who might be at risk or might actually, in fact, have cognitive impairment or dementia. So I wanted to point out that we actually do have our data more disaggregated by language, and in our Spanish-speaking population, for whom we've done the majority of our screens actually have been in Spanish language, the positivity rate is around 36%. So there's a higher rate, and I don't have all of the data of disaggregating that further, but that is something that we are working on. Let me catch up. So in terms of our next steps, looks like the computer froze. Oh. Okay, good. You guys can see that? Okay. Next steps, no more paper. So again, Mother Earth, we're trying. So Cerner is our electronic health record, and there actually wasn't any tool in our electronic health record. So for those of you who are clinicians, and I know many of you are, your life, your workday is pretty much dictated by the EHR, right? And I think that building it into the EHR has been critical to make sure that this is sustainable. So we're actually building this, and it's set to launch in the spring. So I don't want to be too optimistic. April, May. We're getting very, very close. We've been working on this for over a year. And we're really trying to customize it so that it is instructive and helpful for the person who's doing it, as well as efficient. And we're really trying to make it so that nurses can complete the cognitive health assessment, the screening, during intake annually for those who are 65 and older who don't already have a diagnosis. The results will be populated into the EHR immediately. There are codes and other bells and whistles that are built in to help us track this population and to really do the right thing moving forward once they are identified as at risk or have an abnormal cognitive health screen. We've been working very hard on this. We're excited for it to launch, even though it's been a lot of technical long meetings to get there. In terms of the team behind Dementia Careware, and there are many more folks across DHS that I'd like to acknowledge, but Dementia Careware specifically, we have our fearless leader, Freddie. There's me, Stephanie, our program manager, who is here and is absolutely essential. She's the wind in our sails. Ellen Wong, who is here, our neurologist, neurobehaviorist. Katie Ward, who has since moved on to become the chief of geriatrics at Stanford, but has been our Harbor UCLA internal medicine lead. Saika Tokumitsu, our geriatrician family physician at MLK, and Emily Chang, who is here as well, who has actually moved on, but is still working with us, but has moved on to a position with Department of Public Health. So we have a great team. We also have Eva Torres and Frankia Medina, who are our program coordinators, more wind in our sails to really make this work. So that's our pilot team. In terms of our key learnings, we have learned and are doing additional research to learn more about what it is that we can do better. So one is that primary care providers need ongoing in-person training opportunities, and that's not at the exclusion of all the wonderful training opportunities that exist online, but they really need that hands-on support. They need that elbow support and coaching. This is really outside of the wheelhouse of many primary care clinicians. They feel uncomfortable, they feel ill-equipped, they feel they don't have enough time, they feel they don't have enough support. But we know, and research shows that actually with the proper training and support and with a team-based approach, that we can get this done. We've done this in other disease states. We can and will do it for cognitive impairment and dementia. We also have learned that manual tracking and paper-based forms is very time and labor intensive. No duh. So we're working on that. And that clinic site champions are essential, especially when there are very few incentives or sort of carrots and sticks, as we say, to getting this done. The one thing that I'd like to point out, and I'm very grateful that the state of California, again, is a leader in this, is that not only has Dementia Careware sort of spurred this conversation and education for early detection, early screening, and primary care, it's really starting to set the bar, and we now have, for our Medi-Cal managed care health plans, a requirement to do this. That has been an enormous lever. So I never thought I would say, yay for more regulatory compliance measures, but actually this is a really important one that's going to drive quality and I believe really health much more than many of the other ones do. But I think this is a place where we're just going to start to see some traction with the health plans, and that is going to be a motivating factor for health systems to do this work. Okay, so our goals moving forward, we are in this year expanding our CHA training and screening to all DHS primary care sites. It's a little daunting. There are over 20 clinics that we're going to be expanding to. I mentioned that if we were doing this for every patient every year, it would be over 50,000 screenings per year for 65 and older, until, of course, we begin to sort of understand who needs to have screening, who actually needs to have further evaluation and or diagnosis. So that's one of our goals, and we're working closely with our DHS leadership on how we're going to get this done. We're also embedding the cognitive health assessment components into our electronic health record and our team-based workflows. As I mentioned, the effort right now is to launch our tool in our EHR. And for those of you who have a great tool in your EHR, please talk to me afterwards, because we haven't launched it yet. We really want to make it as user-friendly, as evidence-based, as clear and concise, efficient as we can. So, and then the last goal that we have is to recruit support from nursing and social work. Nursing and social work are our partners, and as we've heard, throughout this conference, and as many of us know, they're really the heart and soul of us being able to support our patients, their caregivers, families, and communities who are living with cognitive impairment and dementia, who may feel that they are not being seen or heard. And so I think that it's really important, and I'm grateful that DHS has actually put champions in nursing and social work leadership behind this effort. For more information, there's my contact information. We also have a really nice poster that will be like Vanna White, showcase our poster if you'd like to look at it afterwards. And thank you very much. Open for questions.
Thank you. How are you embedding the clock drawing test into your EMR?
Such a good question.
Yeah.
The short answer is we're not. So the clock draw test
Do it on paper?
Yeah,
Yeah.
can be done on paper. You need to draw a circle. Doesn't have to be a good circle, and have a pen and paper, and you're good to go. But I would like to point out that we've got an alternative to the clock draw test as part of our mini cog. So I don't have a slide, I think, with the actual tool. I apologize. I think that somehow got taken out or hidden, but our tool actually has on the paper form the clock draw already printed, but it has an alternative animal naming task so that people who either can't because of physical or mobility, or they're on a telehealth visit, it's really hard to do and score that unless you're maybe on video. So we also have the alternative animal naming task. Thank you for that question.
Hi, I'm Linda with another question over here.
Oh, hi.
So I have a client on my caseload who is kind of starting to show some cognitive impairment, cognitive decline. And so our solution with our interdisciplinary treatment team is to refer them out to a neurologist. So we're referring them out to a neurologist, and that's taking forever. And now the person has declined even more, and we're still at now the next IDT meeting. And how's that neurology consult? Well, it hasn't happened yet. So my question is, I was super excited to see nurses and social workers. I would love to see this as an assessment as part of our admission intake. So how do I make that happen in my facility?
Wow. Thank you for that question and comment, and for being a champion for not only the patient you just talked about, but clearly for this whole issue. I think that there are many tools that are evidence-based and fully within the scope of practice of most of the healthcare team members in terms of doing a screening and additional education support for patients and families, short of that, full neurological exam assessment battery. I think that, talking with your leadership about what it is that you'd like to do and why, and some of the tools that I'm happy to share with you that are available on Dementia Careware and in other places. I know there's folks at the tables who would probably love to talk with you as well. But this is where it's at, is really motivating people who are on the front lines, who are seeing patients and families really suffering and their health deteriorate as they're waiting for specialty referrals that are really not always the answer. They might be part of the answer, but they're not usually the only answer. Yeah, thank you.
Thank you, Heather.
Oh, thank you.
Take this down.
Sure.
Oh, one more question. Okay, one more question. And I'll take
Sorry, I couldn't see you back there.
Hi, Sahar. Thank you, Heather. Quick question. So with the current, like for the past year, what have you guys been doing with the positive results?
Great question. So we actually have started a pilot research project to look at, or it's more of a quality improvement project to look at the positive CHAs and to see what happened. And I'm going to speak on behalf of the team that's really leading this at MLK. They have done chart reviews of positive CHAs. They have found that it takes time to make the diagnosis in primary care. It's not something that within a 3-month or a 6-month period, you're necessarily going to have a diagnosis. There's probably going to be a lag time in the next appointment. There's probably going to be some additional evaluation. One of the things that we have found already, and it's very nascent, it's just started, is that there's very high crossover with depression, screening for and diagnosing and managing depression in our population. There's, of course, labs and studies and other things that are ongoing in the evaluation. Many of the patients who have been screened positive are referred to the geriatrics clinic, not necessarily neurology, but to our geriatrics clinics, but we know that there are not geriatrics clinics across the whole county to support all of the positive screens. And then interestingly, it's been found so far in our prelim data that there's increased conversations documented around advanced care planning for those who have screened positive. So I'm really excited about that, happy to talk about it further. We do have, as a primer, we do have a California Department of Public Health grant for the next 4 years, starting this July, to look at all of our positive screens. So we're doing a pilot, but we're gonna have more data over the next couple of years, fill that gap. Thank you.
Thank you. Thank you. Thank you. Great. Thank you.